A 2-year child with 7.5 kg weight with vitamin A deficiency, oral dose of vitamin A given is. Okay, what is the answer? Everyone in the comment section, please. Exactly the right answer, 1 lakh international units. So if we talk about the prophylaxis, if we talk about, first of all, vitamin A deficiency, the first symptom will be night blindness. The first symptom will be night blindness. Okay, if we talk about the first sign of vitamin A deficiency, the first sign will be very good, conjunctival xerosis. Conjunctival xerosis. Okay, guys, most common clinical sign, if I ask most common clinical sign, then the answer will be bite or spot. Is that clear, guys? Now, if we talk about as per the age, how much vitamin A you have to give, we already know less than 6 months. We give how much, guys? 50,000 international units. Very good. 50,000 international units. Okay. Less than 1 year. Like that means 6 months to 1 year. We give how much, guys? 1 lakh international units. 1 lakh international units. And more than 1 year, we give 2 lakh international units. Okay. So, but here what I have mentioned is that the age of the baby is 2 years. That is more than 1 year. So as per the age, it should be what? It should be 2 lakh international units. But the one more criteria, when the weight of the baby is less than the 8 kg, when the weight of the baby is less than 8 kg, you have to give 1 lakh international units. If it would have been more than 8 kg, then the answer would have been 2 lakh international units. 2 lakh international units. Okay, what is the richest source of vitamin A? Guys? What is the richest source? It's halibut oil. The second richest is liver oil. And if we talk about vegetable, then it's carrot. Is that okay, guys? And total doses of vitamin A, how many, guys? Total 9 doses. Okay, what is the total amount? Total amount is 17 lakh international unit. 17 lakh international unit. And you have to give every 6 months. Every 6 months till 5 years. Okay, very important question, guys. Multiple times it has been asked. So vitamin A deficiency, guys, the first symptom will be night blindness. The first sign will be conjunctival xerosis. And the most common clinical sign, if I talk about clinical sign, then it's bite or spot. Is that clear to everyone, guys? And the most sensitive screening test, if the question is most sensitive screening test, then your answer will be serum retinol levels. Is that clear, guys? Is that clear, everyone? Okay, so the answer is 1 lakh international units. Okay, less than 1 year, 1 lakh international unit. More than 1 year, 2 lakh international unit. Less than 6 months, 50,000. But if the weight of the baby is less than 8 kg, then you have to give 1 lakh international unit, even if the age is more than 1 year. Clear to everyone? Is this clear to everyone? Yes, sir. Okay, can we move to the second question, guys? Yes. That's all you have to remember for this vitamin A, guys. Okay, now I've mentioned all the symptoms. What can be the first symptom, first sign? Okay, sir, clear. Okay, let's move to the next question. A study was conducted on a group of 500 patients having carcinoma lung, and another group of 300 was chosen from the general population. Both these groups were questioned on their exposure to the smoking. What kind of study this is? What kind of study this is, guys? Write down in the comment section. Very good, everyone. Yes, all of you got it correct, guys. The answer is case control study. Okay, case control study. Yes, I'm going to discuss that. Muralidhar, I'm going to discuss that. Okay, so let's discuss about first case control study. Okay, case control study. Okay, case control study, it is opposite to the cohort study. First of all, it's opposite to cohort study. So I've already mentioned the question related to the cohort study. So at that time, I'll discuss whole cohort study. This time, we'll just discuss what is case control study. Okay, the case control, it is the study. It's the study from disease to the risk factor. From disease to the risk factor. Okay, that is why it's also called. That is why it's also called a retrospective study. That's why it's also called as retrospective study, or it's called as backward study. Backward study. That means, guys, even the disease at the time of study, the disease is present as well as the risk factor is present. Both the things are present at the given time. Okay. So what we do in the case control study, we have a disease and we go back to the history. For example, if the patient is having a liver cancer, then we are asking the history. We are asking the patient, do you drink back in your past? If the risk factor is present and the disease is already present, so please go a bit fast on the easy topics, guys. Okay, no, topics are same for everyone, so let me go a bit faster. Okay, so what's mentioned in there, guys, what I was talking about is case control study. Okay, so that means you're going back in the past and discuss the cases over there. Okay, so a disease is already present over there, patient is already having the liver cancer, then you're asking about the risk factors, whether you are consuming alcohol in your past or not. The same case here, the patient is having which 500 patients is having a lung carcinoma. Okay, and another group 300 was chosen from the general population, and both these groups were questioned on the exposure to the smoking. So you are going back, and when you are going back in a study, that study is called as case control study. Case control study. Okay, now if you go forward, for example, right now 50 people are consuming the alcohol. Okay, so you are telling them, after 5 years I will go for the fibroscan. After 5 years I will go for the investigation that can let me know about the carcinoma of the liver. Are you getting my point, guys? So you're going forward. That is a forward study, or either we call that prospective study. That is called as cohort study. But when you go back into the past, guys, that is called as case control study. So simply, guys, from the clinical scenario, this is clearly mentioning that, okay, the disease is present and you are going back into the past and checking about the risk factors. This study is called as case control study. This study is called as case control study or the backward study. Okay, we can also call it as, guys, outcome to exposure study. Outcome to exposure study. Outcome to exposure study. And it's a very fast study. Very fast study comparatively to other studies, because both risk factor and the disease is present. In cohort study, you have to wait for the outcome, right? You have to wait a years for the outcome. So that's why, which study is faster, guys? Case control study. Okay, and the strength of association is given by odds ratio. So odds ratio is calculated in which kind of study, guys? Case control study. Guys, 2022 June FMG question, simple one-liner was asked. Incidence is checked in which type of study? Incidence is checked in which type of study? Simple question, guys. Cohort. Simple cohort. Okay. And if the odds ratio, that is in the case control. Then later on, guys, we have an interpretation of the odds ratio depending whether the value is 0, less than 1, or more than 1. That's not needed here. Okay. In FMG, simple question will be asked. So let's not mug up it. Okay. So guys, this is the thing you have to remember about the case control study. Rest other studies I'm going to discuss in the other slides. Okay. So case control is a backward study. Okay. And the strength of association is given with the help of a odds ratio. Is that clear? Is that clear, guys? Sir, why this is a fast study? It is very fast study, guys, because you don't need no follow-up. There is no follow-up. Are you getting my point? There are no new cases, no follow-up. You have right risk factor and vascular disease present at the same time. But in cohort, if you're waiting, if you're studying for that, if you're having a particular study on a particular condition, okay, you have to wait till you get the outcome. You have to wait years. It can be 5 years, 7 years, 10 years. For example, if you take the example of the carcinoma cervix, from CIN1 to CIN2, it takes 5 years. Then from CIN2 to CIN3, it takes 10 years. Are you getting my point? So that is a long study. Okay, you have to wait for the particular outcome when the more than 1/3 cells will be having dysplasia. Then only the cervical cancer will happen. So, but here, disease is present. You're just going back. There are no follow-ups, nothing. That's why it's a fast study. Is that clear? Okay. Okay. Now, next question, guys. In the coming slides, I'll discuss that, Ishita. So which of these is the correct dosing schedule according to the given program logo? What is the logo, guys? Anemia Mukt Bharat. What's your answer? How much iron and folic acid to be given in case of a pregnant lady, guys? The answer is, everyone, very good. The answer is C, 60 mg of elemental iron with a 500 micrograms of folic acid to the pregnant woman daily. Okay. So if we discuss the importance of the folic acid in the pregnancy, guys, folic acid will decrease what? Decrease the neural tube defects. It will decrease the neural tube defects. Okay. Now tell me, guys, what is the dosage of the folic acid in the pregnancy? For the folic acid, it is 0.4 mg daily. But if the patient is having a history of neural tube defect, for the history of neural tube defect, it will be 4 mg daily. Is that okay, guys? Is that okay? Yes. So what is the most common neural tube defect? If you remember, most common neural tube defect is spina bifida. And most common spina bifida is spina bifida occulta. Very good. And which anemia folic acid? If there is a deficiency of folic acid, megaloblastic anemia. Which anemia, guys? Megaloblastic anemia. It's also caused by vitamin B12. Then from the biochemistry part, you differentiate with the homocysteine and MMA levels. And with the clinical features, if you want to differentiate it, that means the neurological features will be associated with the which type of anemia, guys? B12 anemia. Is that clear? Now, let's discuss this Anemia Mukt Bharat, guys. At what age, how much amount of iron and folic acid you have to give and with what frequency? Okay. So we have already discussed in our main classes of the PSM, guys. If we talk about the time, that means 6 months to 5 years. If we talk about 6 months to 5 years, how much iron you have to give, guys? 20 mg and 100 micrograms of folic acid twice a week. Twice a week. If I talk about 6 years to 10 years, guys, 6 years to 10 years, 45 mg of iron and 400 micrograms of folic acid twice a week. 400 micrograms folic acid twice a week. If I talk about 10 years to 19 years, 10 years to 19 years, you have to give 60 mg iron and 500 micrograms of folic acid weekly. if 19 years till 49 years, okay, same guys, 60 mg of iron and 500 micrograms weekly. And the important one guys, in pregnancy and lactation, both guys, 60 mg of iron, 500 micrograms of folic acid daily. So that was the question guys, how much iron and folic acid as per the anemia Mukt Bharat will be given to the pregnant lady. So that is 60 mg of iron and 500 micrograms of folic acid. Is that clear guys? But yes, according to that, tell me what is the WHO cutoff for the anemia in pregnancy? What is? It's less than 11 guys. Okay, anemia in a pregnancy. Okay, how much? It's less than 11. It's less than 11. Normal males, normal male and female. Males, it's less than 13. Females, it's less than 12. It's less than 12. Yes, very severe if it is, it's less than 4. And okay. And we have already mentioned, guys, I've already mentioned one more thing about this. Once we have a anemia in pregnancy, we also deworm the patient. We also deworm the patient. We also deworm the patient. Okay, we give what drug guys? Albendazole. Albendazole, because worms can also cause the anemia. Which worm guys? Hookworm. Hookworm. Very good. Yes, albendazole 400 mg. Very good. Okay, which worm causes anemia guys? Hookworm. Okay, so that was all about the and most common anemia in pregnancies. Most common anemia in pregnancies. Most common anemia in pregnancy is nutritional anemia. It's nutritional anemia. Is that clear? All about anemia Mukt Bharat? Everyone? Yes. So guys, remember this is the logo of the Anemia Book Bharat, and we have a 6 into 6 into 6 strategy. That was the PYQ guys. But still guys, remember this time the values, how much amount of folic acid and iron to be given in a pregnant lady. Is that clear to everyone? Can we go to the next question, please? Yes. All clear to everyone? BD. Okay. Okay, guys. Physical quality of life includes the following parameters. Okay, guys. Physical quality of life include the following parameters except. So PQLI. Guys, we have studied in the indicators of the quality life. What will be the answer, everyone? Yes. Okay, whosoever is marking the answers, iPad here, please don't mark the answer directly on the screen, okay? You are not little kids, guys. Life expectancy at birth. Life expectancy at birth. Life expectancy at birth. Okay, let's discuss the indicators of life. Let's discuss the indicators of life, guys. We have physical quality of life index, that is PQLI, and human developmental index, HDI. Is that okay? So tell me the components, guys. Tell me the components of PQLI, guys. It's life expectancy. It's life expectancy at 1 year of age. At 1 year of age. Life expectancy at 1 year of age. Number second is literacy rate. Number second is literacy rate. Number third is infant mortality rate. Infant mortality rate. Infant mortality rate. The range of PQLI. The range of PQLI is 0 to 100. The range of PQLI is 0 to 100. And the current value of the India is, okay, 71. Remember, guys, 71. Current value is 71. That is a physical quality of life index, the components. Okay. I have multiple times tell you guys, just remember the components. They will tell you out of which of the following, except in HDI, either PQ, LI. Then the components of HDI, it's life expectancy at birth. It's life expectancy at birth. It's literacy rate, or another name we can use, guys, synonym, knowledge. So either they will mention literacy rate or they can mention what? Knowledge. Okay. And the third component is income. The third component is income. The range is between 0 to 1. The range is between 0 to 1, and the current value is 0.645. Is 0.645. If we talk about the rank of India, rank right now is 131. Rank right now is 131. Okay, so these are the components of physical quality of life index and HDI. Now literacy rate, guys. Literacy rate, we have a different synonyms for that. Either they can mention educational index. They can mention educational index. They can mention mean year of schooling. Mean year of schooling. Or they can mention knowledge. They can mention knowledge. We have other indicators. We have other indicators of the quality life. Just remember the names, guys. We have human poverty index. We have human poverty index. We have human suffering index. And we have multi-dimensional poverty index. Okay, so that was all about the indicators of life. Then we have indicators of health as well, and mortality, morbidity, disability. That's already mentioned in the workbook, guys. Please go through these topics. Okay, so right now just remember main important PQLI and HDI. The components, guys, what are the components of the PQLI? Life expectancy at the 1 year of age, literacy rate, and infant mortality rate. Okay, and about the human developmental index, what are the three components we have? Life expectancy at birth, literacy rate, and income. Is that clear? Is that clear, guys? Yes, sir. Yes. So let's move to the next question. Okay. A person with a history of 30 years working in the cardboard manufacturing industry develops breathlessness and cough. X-ray shows mottling in the lungs. Disease most likely he's suffering from, guys. So what is your probable diagnosis? What is your probable diagnosis, guys? It is a, yes, pneumoconiosis. Which pneumoconiosis, guys? Bagasosis. It is a bagasosis. Okay, so let's discuss about, guys, bagasosis. One by one, let's discuss about every pneumoconiosis. Okay, so guys, most common pneumoconiosis is, if I talk about most common pneumoconiosis, it is silicosis. Very good. It is silicosis. It is silicosis. Okay, which industry? Which industry, guys? Cement industry, or glass industry, or bauxite miners. Okay, silicosis. If we talk about the chest X-ray of silicosis, guys, we have snowstorm appearance. We have snowstorm appearance. You will see that in your radiology image, guys. Snowstorm appearance. And which calcification we have? Egg shell calcification. Which calcification we do have, guys? Egg shell calcification. Okay, and we advise patient usually to follow up for which condition, guys? Because they are more prone to tuberculosis. They are more prone to tuberculosis. Is that okay, guys? Is that okay? Okay, and pneumoconiotic particle that are dangerous is less than 5 microns. Okay, usually it's 0.5 to 3.0 or less than 5 microns. That was about silicosis. If we talk about bagasosis, the dust is guys sugar cane dust. The dust is sugar cane dust. Okay, the dust is sugar cane dust. What is the fungus, guys? What is the fungus? Thermoactinomycetes. Very good. Thermoactinomycetes saccharine. Very good. And how do you prevent it? 2% propionic acid. How do you prevent it, guys? 2% propionic acid. Okay. Then you have one more very important one, guys. Asbestosis. Asbestosis. Okay. Asbestosis. Okay. This is a which dust, guys? Asbestos dust. The more important question from this part that they can ask you, the more important question that they can ask, it's the only pneumoconiosis associated with malignancy. Associated with malignancy. Okay. Only pneumoconiosis associated with malignancy. If the question mentions most common malignancy will be adenocarcinoma of lung. The most common malignancy will be adenocarcinoma of lung. And most specific will be mesothelioma. The most specific will be mesothelioma. Okay. The pathological bodies in asbestosis are the Ferguson bodies. Remember this? Ferguson bodies. Okay. And in mesothelioma, what bodies we have? Very, very common question. Samoma bodies. Hai na, guys? Samoma bodies. They are also seen in a lot of conditions like papillary thyroid cancer, in case of an ovarian tumors, in case of meningioma. Hai na? Along with that, we have orphan nuclear and papillary thyroid cancer. Okay. So that was all about asbestosis. Then one more, guys, very important. We have anthracosis. Anthracosis. What is the agent, guys? What is the agent? We have coal dust. Anthracosis. We have which agent, guys? Coal dust. Okay. And there is progressive massive fibrosis in anthracosis. Massive fibrosis in anthracosis, guys. Okay. In anthracosis. And if there is anthracosis plus rheumatoid arthritis, which syndrome? Guys, from the medicine point of view? Kaplan syndrome. It's called as Kaplan syndrome. It is also called as rheumatoid pneumoconiosis. One more name, remember, it's also called as rheumatoid. It's also called as rheumatoid pneumoconiosis. It's also called as rheumatoid pneumoconiosis. Is that clear, guys? Everyone? So anthracosis plus rheumatoid arthritis is Kaplan syndrome. Is that okay? There are multiple rounded opacities on the chest X-ray. Okay. Multiple rounded opacities on the chest X-ray. Is okay? And if there is a rheumatoid arthritis plus neutropenia plus splenomegaly, that is called which syndrome? That is called which syndrome, guys? If you have a rheumatoid arthritis plus neutropenia plus splenomegaly Okay, the syndrome is called as Felty syndrome. The syndrome is called as Felty syndrome. The patient will present with the non-healing leg ulcers. Okay, that is what syndrome? Felty syndrome. And Kaplan is pneumoconiosis plus rheumatoid arthritis. Which pneumoconiosis, guys? Related to the coal dust called anthracosis. So anthracosis, that's why it's also called rheumatoid pneumoconiosis. It's also called rheumatoid pneumoconiosis. Then we have one more important one, guys. Byssinosis. Byssinosis is related to the cotton dust. And one more important finding. Cotton dust. One more thing. Which day? Monday, Tuesday, Wednesday. Monday, Chest tightness. Yes. Is that clear, guys? Okay. All the pneumoconiosis. Okay. Then we have also studied farmer's lung, called moldy. Hey, that is a dust of a grain husk. That is a dust of the grain husk. And how do you prevent that? 1% mineral oil. Guys, pneumoconiosis are very important. Guys, you might feel the questions are easy, but the only reason to drop these questions is just to revise the whole topic. Okay. So that question will come around the same topic. Okay. Yes. And the bacteria, microspora fani. Yes. And berylliosis with the ES space. Very good. Clear to everyone? Everyone. All 130 people. Good. Good. Any doubts from till now? We are all clear, guys? Yes. Okay. Can we move to the next question, guys? Sir, Kaplan syndrome. Kaplan syndrome is nothing, just anthracosis, pneumoconiosis plus rheumatoid arthritis. We call it as Kaplan syndrome. Okay. And I've told you the same, a bit similar X-ray will be having a multiple opacities. You know, like in case of a cannonball appearance, you have multiple opacities, balls. A bit similar. I will not tell the same. A bit similar X-ray directly in case of a Kaplan syndrome. Okay, guys. Yes. Now, the next question, a patient with a hypopigmented anesthetic patch with one thickened nerve present to your OPD. What shall be your treatment approach? What is your diagnosis first, guys? Simply, what is your diagnosis, guys? Leprosy. What is your diagnosis, guys? Leprosy. Now, patient is having less than 5 lesions. Less than 5 means bacillary. Less than 5 means bacillary. Okay, guys. So let's discuss a type of leprosy first. Guys, if we have two, bacillary and multibacillary. Bacillary and multibacillary. If case of bacillary, number of skin lesions, if I talk about number of skin lesions, we have how much, guys? Less than 5 or 1 to 5. Here we have more than 5 lesions. Guys, drugs, we use 3 drugs that are same in both of the conditions. What are the 3 drugs, guys? Rifampicin, dapsone and clofazimine. Okay, guys. Dapsone, rifampicin and clofazimine. Rifampicin is also used in case of TB drugs, anti-TB first line management with a side effect of orange or red color secretions. Right, guys? Dapsone is a drug of choice for, in which condition in dermatology we have studied, guys? Dermatitis herpetiformis. And one more condition. Anyone? One more condition. Linear IgA. Very good, Vismay Das. Very good. Linear IgA. Okay. And clofazimine is also a new anti-TB drug that is used. Okay, guys. So rifampicin, dapsone, and clofazimine, all 3 drugs are used in case of leprosy. Okay. Now, the duration of the treatment in bacillary, the duration of the treatment for here we use 6 months. In case of bacillary, we use 6 months. And in case of multibacillary, we use for how many months, guys? 12 months. Okay. And here you have yearly follow-up for 2 years. Follow-up yearly for 2 years. And here yearly for 5 years. Yearly for 5 years. Then more points about leprosy, guys. Very few. Usually they ask the lepra reaction. What they usually ask? The lepra reaction. We have rule of 5. Again a PYQ, guys. Rule of 5. In type 1 lepra reaction, which hypersensitivity, guys? Okay. Which hypersensitivity? Type 4 hypersensitivity. So what you will add to 5, it will become, what will you add to 1? It will become 5. 4. So 4 plus 1 is 5. And in type 2 lepra reaction, guys, what is the hypersensitivity we'll have? Very good. Very good. We have type 3 hypersensitivity reaction. So rule of 5 means if there is a type 1 hypersensitivity reaction, the easy way to remember is what you will add to 1, it will become 5. You have to add 4. Are you getting my point? So type 4 hypersensitivity reaction in the type 1 lepra. Okay, and type 2 lepra reaction, we have which hypersensitivity? Type 3 hypersensitivity. Type 3 hypersensitivity. Okay. So guys, it is not a diagnostic test, lepramin test. It is a screening test, and the most common nerve involved is ulnar nerve. Yes, got it, guys. So what will be the answer? You have a paucibacillary leprosy as a diagnosis with less than 5 lesions. So what will be your treatment, guys? You will give 3 drugs. What are 3 drugs? Rifampicin, dapsone, and clofazimine for how many months, guys? 6 months. For how many months? 6 months. Okay. And the reading you will give, guys, after 48 hours and after 21 days. Then they have a reaction, Fernand's reaction and all. That is okay. Okay, can we move to the next question, guys? Can we move to the next question, everyone? Everyone. Very good. Okay. Asha worker during her house visit in a village of Bihar came across a patient complaining of the fever, weight loss for 3 months. She noticed that the skin was dark and abdomen distended. She performed, that is the plus point, guys, that she performed RK39 dipstick test. A test you have to remember no matter what. On urine, which turned to be positive. The probable diagnosis is, what is the diagnosis first? RK39 dipstick test. What is the diagnosis? Okay, everyone. What is the diagnosis, guys? Everyone. Yes, the answer is Leishmaniasis. Very good. The answer is Leishmaniasis. Okay, let's discuss whole Leishmaniasis, guys. Before that, the option number A was leprosy. You already know D. It's not. The option A was filariasis. So let's discuss about filariasis first. Then we'll discuss about the Leishmaniasis. Okay. Very bacha question. You remember this from the microbiology point of view. Okay. What is the agent for filariasis? What is the agent for filariasis? What is the agent for filariasis, guys? Wucheria brancofti. Wucheria brancofti. We have also Brugia malai. We have also Brugia malai. Very good. Brugia malai and Wucheria brancofti. Okay. So diagnosis, guys. Diagnosis here we have a one test. Just remember the test: membrane filtration test. Membrane filtration test. Membrane filtration test. Which condition? Whenever you see in a question, they are talking about a membrane filtration test. Like in here, RK39 dipstick test, you already know Leishmaniasis. If they mention membrane filtration test, what will be your answer, guys? Filariasis. What is the agent? Wucheria brancofti and Brugia malai. Wucheria brancofti and Brugia malai. And there is a drug that we give with a triple therapy. Drug क्या देंगे? Treatment क्या देंगे, guys? There is a triple therapy AID. AID. A for albendazole. A for albendazole. I for ivermectin. I for ivermectin. And D for diethyl carbamazine. D for diethyl carbamazine. Okay, guys. Dimethyl carbamazine. DEC. DEC. That was all about filariasis. Yes, we also go for peripheral blood smear. Okay. Then if we talk about now important one, Leishmaniasis. If we talk about Leishmaniasis. Yes, filariasis. In filariasis, multi-purpose worker male will go for peripheral blood smear. Is that okay? Yes. So if we talk about Leishmaniasis now, if we talk about Leishmaniasis, guys, what is the agent? What is the agent? Leishmania donovani. Okay. It's also called as visceral Leishmaniasis. Visceral Leishmaniasis. Okay. Kala azar. Okay. Then we have Leishmania tropica. We have L. tropica as agent for cutaneous Leishmaniasis. For cutaneous Leishmaniasis. Guys, your microbiology is also getting revision, है ना? You already know this thing. So what is the test you do here? What is the test you do, guys? RK39 dipstick test. RK39 dipstick test. Okay. And what are the bodies? What are the intracytoplasmic inclusion bodies? Intracytoplasmic inclusion bodies found in Leishmaniasis are inclusion bodies. What are the bodies, guys? कौन सी bodies दिखती है हमें? Leishmania Donovani bodies. I will write in the short LD bodies. I will write in the short, guys, LD bodies. LD bodies. Okay. We do one test to check the immune status of the patient in the Leishmaniasis. What is that test, guys? Leishmania test. Leishmania test also we do. And what will be your drug of choice? What will be your drug of choice? It will be L-amphotericin B. It will be L-amphotericin B. How much you give, guys? 10 mg per kg. Okay. 10 mg per kg IV single infusion. That is a treatment for Leishmaniasis. You don't have to remember the dosage. Just remember L-amphotericin B. And L-amphotericin B is the drug of choice for other condition as well as mucormycosis ho gaya. Number one thing. Number second is cryptococcal meningitis. Cryptococcal, yes, second drug of choice is Milliform. Don't need to go deeper. Just remember cryptococcal meningitis, L-amphotericin B, है ना? Mucormycosis, L-amphotericin B. Kala azar or Leishmaniasis, L-amphotericin B. Is that okay? And to control the vector, we use insecticides, dichloro, diphenyl, trichloroethane. That is DDT. Is that clear, guys? Leishmaniasis and filariasis are clear? Yes? Done, guys? Everyone? All clear? Yes, I'm going a bit faster because we have already revised it multiple times in our regular classes. Can we move to the next question? Good. Thank you. A factory worker had a history of frequent exposure to the groundnuts. Subsequently, he develops hepatocellular carcinoma. Most likely exposure association is. Which exposure is there, guys? Which exposure is there? It's a very easy question. PYQ, guys. It's aflatoxin. It's aflatoxin. What will be the disease? Aflatoxicosis. What will be the disease, guys? Aflatoxicosis. Is that clear? So let's discuss these food adulteration diseases. So first of all, if I talk about latherism, guys, what is the toxin? In latherism, what is the toxin? BOA. What is the BOA, guys? What is the BOA? Beta oxalyl amino alanine. Beta oxalyl amino alanine. Beta oxalyl amino alanine. Okay. If I talk about the agent for latherism, what is the agent, guys? Kesari dal. Okay. Kesari dal. What is an agent, guys? Kesari dal. And the food stuff is yellow pulse. And the food stuff is yellow pulse. Is that okay? Yellow pulse. If I talk about second one, epidemic dropsy, guys, what is the toxin? The toxin is sanguine. Okay. And the agent is argemone seed. The agent is argemone seed. And the food stuff is mustard. And the food stuff is mustard. Is that clear? Now the third one, guys, if I talk about endemic ascites, what is the toxin? Pyrrolizidine. What is the toxin, guys? Pyrrolizidine. And the agent is Coroterella seed. And food stuff is millet. Food stuff is millet. Then aflatoxicosis, guys. Which toxin? 2 times this has been asked in the MCI. Aflatoxin. Which cancer, guys? Hepatic cancer. Okay. And the agent is aspergillus flavus. And foodstuff is grains or groundnut. Groundnut. Then the last one, guys, ergotism. Okay. So the toxin is ergot alkaloid. The toxin is ergot alkaloid. Okay. And the agent is claviceps fusiform. Very good. Claviceps fusiform. And the last one, foodstuff, are the flowering plants. So this is all about, guys, food adulteration disease. And this multiple times they have been asking, guys, this. So remember aflatoxicosis, and all other are important, guys. They cannot ask every time aflatoxicosis. They can ask epidemic dropsy or endemic ascites, but it is very important. So guys, only associated with the hepatic cancer is which one, guys? Aflatoxicosis. Aflatoxicosis. Can we move to the next method, guys? Sorry, can we move to the next question? All clear? Yes. Speed is okay, everyone. Okay. Perfect. Good. One of the methods of health communication where 4 to 8 persons are qualified to talk about the topic and discuss a given problem in front of a large group of audience in sequence. Yeah, important part. In sequence. The method is called. The method is called. Everyone answer. The method is called. What will be your answer? What will be your answer, guys? Good. Very good. Yes, the answer is symposium. The answer is symposium. Those people who are marking it panel discussion, let me tell you, guys, in panel discussion, yes, there are 4 to 8 persons. Yes, there are 4 to 8 persons. Okay. They will discuss a problem or the topic in front of a large audience, but there is no sequence. Okay, no set of order of speaking. Yes, there is no sequence, no set of order of speaking in panel discussion. But when they mention in sequence, but when they mention 4 to 8 person, but when they mention 4 to 8 persons in a sequence, they are delivering, for example, they are delivering, that is a symposium. Panel discussion may, for example, news channels, you'll see debates, anyone is coming and just speaking. Okay, so yes, very good, SK. S for sequence, S for symposium, है ना? S for sequence, S for symposium. That is a good idea to remember. Okay, if we talk about workshop, if we talk about workshop, there is series of more or more than 4 meetings. Series of more or more meeting. What is the purpose of this workshop, guys? To impart the practical skills. Okay, there is a proper group work, then a group discussion, and then the plan of action. That is a workshop. If I talk about, guys, the best one among all, IPC, that is interpersonal communication. Interpersonal communication, IPC. Which one is the best among all? IPC. Okay, guys. So there is a face-to-face communication. There is face-to-face communication. Okay, guys. There is face-to-face communication. Okay. And best among all is IPC, followed by focal group discussion. Okay. In focal group discussion, there is a discussion among how many people, guys? 6 to 12 persons. Okay, there is one group leader and one recorder. Okay, then seeing is believing, learning by doing. Seeing is believing, learning by doing for ORS, demonstration. Okay, so you will remember seeing is believing. Seeing is believing, learning by doing. Learning by doing. In case of which communication, guys? Demonstration. Is that okay? Then we have other techniques as well as spikes techniques, gather approach, for contraceptions, gather approach for spikes. When you have a particular big disease and you have to tell to that family, you have to go for all the techniques that I've mentioned in the spikes. Please go through those topics that I'm already in the workbook, So that is all about this topic. Is that okay? Methods of communication, guys. So what is the answer? Symposium. When there is a sequence. When there is no sequence, there is a panel discussion. There is panel discussion. Okay, then we have a lecture method, chalk and talk method. Okay, but the best one is IPC followed by focus group discussion. And remember ORS wala, seeing by believing. Seeing is believing, learning by doing. Is that clear? Can you go to the next question? Yes, sir. Let's discuss the best parameter for the assessment of acute malnutrition. The best parameter for assessment of acute malnutrition. What is the answer? For acute malnutrition? Everyone? For acute malnutrition. Okay. These are the growth monitoring ways at Anganwadi ICDS centers. Okay, very good. The answer is B, weight for height. Weight for height. Okay. So if we discuss, guys, if we discuss weight for age, weight for age, this is for acute plus chronic, acute plus chronic undernutrition. Okay, if weight for height, weight for height will be for acute malnutrition. Acute malnutrition, yes, or wasting. Okay, or height for age, that is for chronic undernutrition. That is for chronic undernutrition. Okay, or stunting. Or stunting. Okay, what is the main aim for growth monitoring, guys? We have to reduce the pediatric mortality. We have to reduce the pediatric mortality. Okay, so guys, tell me two conditions, two types of malnutrition. Let's discuss that. Two types of malnutrition. कौन सा है, guys? Yes, very. We have kwashiorkor. We have kwashiorkor. And the second one, we have marasmus. The second one, we have marasmus. If I talk about kwashiorkor, guys, there is low protein, but the energy is normal. We have low protein, but energy normal. Energy normal. Yes. In marasmus, what do we have? Low protein. Low protein with low energy. Low protein with low energy. Low protein with low energy. And guys, in kwashiorkor, what type of face we have? What type of face we have? Moon face. Moon face also you have in Cushing syndrome, na? Increased cortisol levels, lemon on stick appearance. So here you will remember moon faces in kwashiorkor. Yes, yes, yes. Chipmunk faces in thalassemia. Yes, chipmunk faces in thalassemia. Okay, and there is a discoloration of the hair shaft, guys. Discoloration, gray hair a bit, called as which sign? Flag sign. Called as which sign, guys? Flag sign. And one more important thing, you have a bulging abdomen. You have a bulging abdomen. That is all you have to remember about kwashiorkor. About the marasmus, guys, there is a thin and brittle hair. Thin and brittle hair. Okay, there is loss of muscle mass. There is loss of muscle mass. And there is which type of face, guys? Old face. Yes, simian phase or old phase. Okay, muscle mass loss hota hai, mara hua, marasmus. Okay, baggy pants appearance. Very good. Okay, guys, that was all about Kwashiorkor. That was all about Kwashiorkor and marasmus. That was all about Kwashiorkor and marasmus. And remember these formulas, guys. Weight for age, weight for height, and height for age. Then in pediatrics revision, you have already studied about the Z score, है ना? Standard deviation and all. Just यहाँ तक, that's enough. Okay, Kwashiorkor and marasmus. Just remember this much. Is that okay? Clear to you, everyone? Is that clear? Can we go to the next question? Everyone, can we move to the next question? Yes, anyone, any doubts? Anything to ask so far? We have revised it multiple times in our regular sessions as well. But right now, okay. Just move to the, which of the following is the least common complication of the measles? Which of the following is the least common complication of measles? Least complication, yes, it's subacute sclerosing panencephalitis. Subsclerosing panencephalitis. Very good. Okay, let's revise whole measles. What is the agent for the measles? What is the agent for the measles? It's RNA paramyxovirus. The agent is RNA paramyxovirus. Okay, what is the incubation period? 10 to 14 days. Incubation period is 10 to 14 days. And the period of communicability. This year, last year, the question was period of communicability. That is 4 days before the rash and 5 days after the rash. 4 days before the rash and 5 days after the rash. For the chickenpox, it is 2 days before the rash, 5 days after the rash. So 45 for measles, 25 for chickenpox. है ना? Incubation period 10 to 14 days and period of communicability 4 days before the rash and 4 days after the rash. You have 3 C's in measles, guys. कौन से? We have cough, coryza, and conjunctivitis. We have cough, coryza, and conjunctivitis. Okay, we have a white spots on the second molar. We have a white spots. We have a white spots opposite to the second molar teeth. What are those spots called as? Coplic spots. What are those spots called as? Coplic spots. Okay, one more condition, guys. One more condition. We have a hyperpigmented line on conjunctiva. We have a hyperpigmented line on conjunctiva. Hyperpigmented line on conjunctiva. What is the line, guys? कौन सी line होती है? Yes, Stenson line. Okay, and most common complication we have is otitis media. Most common complication that we have is otitis media. We also have a pneumonia as the complication as well. Okay, we can have a diarrhea as well. Yeah, but the most common, if you have to answer, otitis media. And a very rare complication that is subacute sclerosing panencephalitis. So just remember, guys, SSPE. I will write SSPE. Is that okay? Okay. The vitamin deficiency associated with measles is which vitamin? Vitamin A. Okay. This vitamin A deficiency is also after the disaster. After the disaster, which vitamin deficiency? Vitamin A. Which infection is most common? Gastroenteritis. है ना, guys? Vitamin A deficiency. Then you are masters in the vitamin A. That was the first question of today's lecture that we had. Okay. You already know about that. And what is the name of the vaccine strain? वो भी डिस्कस करते हैं. वैक्सीन स्ट्रेन कौन सी है हमारी? Edmonstone Zagreb. Okay, guys, you have to give 0.5 ml. You have to give 0.5 ml. Which route? subcutaneous. Okay, 0.5 ml subcutaneous. That was all about, guys, measles. Is that clear? Okay, Koplik spots, Stimson line, otitis media as a complication, rare as SSP. Okay, agent you have to remember. It's also called rubiola. लिख दो, rubiola भी बोलते हैं इसको, rubiola. Okay, guys. Sir, 3 C's of asthma. 3 C's of asthma. You have Kirschmann spirals, charcoat-laden cells. Okay, Kirschmann spirals and Crayola bodies. 3 C's of asthma. Write it down, guys. Just write Crayola bodies. Crayola bodies. You have Kirschmann spirals. Look out for the spelling, guys. And you have charcoat-laden cells. You have charcoat-laden cells. That are 3 C's. That are 3 C's. Let's not go to patho or medicine, guys. Let's stick to our PSM. Okay. Crayola bodies, Kirschmann spirals, and charcoat-laden cells. Is that clear? Yes. Okay. Under ESI Act, sickness benefit is given for a period of. Under ESI Act, the sickness benefit period is given for. Under ESI Act, the sickness benefit is given for a period of. Yes. How many days? 90 days or 91 days. Is that clear? So let's discuss, guys. Okay, let's discuss all the things, the facilities that they have, guys. So if we talk about, guys, sick leave, if we talk about the sick leave, that is given for 3 months or 90 days. 3 months or 90 days. And in these 3 months, how much salary it will be given, guys? 70% of salary. 70% of salary. Okay. Then if I talk about extended sickness, extended sickness, then that is up to how many years? That is up to 2 years. That is up to 2 years, and 80% of salary will be given. And 80% of salary. If I talk about maternity, if I talk about maternity leave, if I talk about maternity leave, that is up to how many months, guys? Up to 6 months with 100% salary. With 100% salary. If there is an enhanced leave, okay, for vasectomy, how many days? 7 days. For tubectomy, 14 days. For tubectomy, we have 14 days. And if there is a disability, okay, the disability benefits, if there is a temporary disability, leave till recovery. Okay, guys, they will give the leave till recovery, and the salary will be 100%. The salary will be 100%. If there is permanently disabled, then pension as per the guidelines. And the last one, if the person dies, the funeral benefits under this act, the funeral benefits will be given 15,000 rupees. 15,000 rupees. Is that okay? Is that okay, guys? Under the ESI Act, the sick leave will be 91 days or 3 months. Is that clear? Guys, ESI Act again is a very, very important. Okay. Now, it's a repeated question, guys. Let's get it. Asha worker coming across a 40-year-old male with a history of fever, with chills and ill-characteristic look during her house-to-house survey. On suspicion of the disease, which type of survey is house-to-house survey, guys? Which type of survey is house-to-house survey? Which surveillance is that? Active surveillance. Which surveillance is that, guys? Active surveillance. Now, if the patient is going to hospital and taking the treatment, passive surveillance. And for the STDs, guys, sentinel surveillance. है active, passive. Okay, we have discussed that. Okay, so guys, on suspicion of the disease which is caused by sand fly included in the National Vector-Borne Disease Control Program, she can perform the following test. She can perform which test, guys? She can perform. Asha is going, guys. It's a National Vector-Borne Disease Program. Okay, the initial test she will go with the RK39 dipstick test. RK39 dipstick test. He's mentioning Asha. These smears, these peripheral thick and thin smear are for the malaria. And malaria के लिए कौन जाता है? Multi-purpose worker male. Okay, we'll discuss the malaria, guys. How to perform the test in the malaria. What can be the diagnostic test? Histidine rich protein, LDH, and a thin and thick smear. One will tell us about the species. One will tell about the presence of malaria. Okay, we'll discuss that. Okay, so RK39 dipstick test. Okay, and this test is done for which condition, guys? Leishmaniasis. This condition, this is done for the Leishmaniasis. Okay, so let's, guys, we have already discussed Leishmaniasis. Let's discuss any other topic. Tell me any other topic in the comment section. Okay, we'll discuss that here. We cannot leave the space blank. That is coming. All the vaccines is coming in the next slides. That is also coming, Nishant. Okay, sir, cancers. Okay, TB drugs and cancers. Fly and vector is almost a table, full table for agents and vectors. I have mentioned in the end. I will be discussing. Let me, yes, okay, cancers. Okay, occupational cancers I will discuss. Okay, cancers and TB drugs. Vaccine strains, also coming vaccine strains. I'm not leaving anything. All important things I have marked up. Okay, I have added up. Okay, so let's discuss, guys. Cancers. So occupational cancer. Most common occupational cancer is? Most common occupational cancer is? कौन सा वाला है? Skin cancer. Skin cancer. Now, guys, let's discuss agents causing cancer. Agents causing cancer. Agents causing cancer. Okay, if I talk about first one, if I talk about asbestos, पहला asbestos. Asbestos को asbestosis कराता है कौन सा cancer? Lung cancer. If I talk about PVC, or if I talk about arsenic, or if I talk about thorotrast, they causes which cancer, my dear students? Angiosarcoma of liver, not bladder. Don't write bladder, Nishant. Angiosarcoma of liver. Now, bladder. If I talk about benzene, that causes blood cancer. Benzene causes blood cancer, leukemia. Now, if I talk about benzidine, there is a D in the benzidine, or aniline dye, that causes which cancer? Bladder cancer. Most common type of bladder cancer is transitional cell carcinoma, TCC. ठीक है ना? Bladder cancer. If I talk about skin cancer, it is caused by chemicals. It's caused by chemicals, oils, or grease. That is a skin cancer. Is that clear, guys? Is that clear? Okay, agents causing cancer: asbestosis, PVC, arsenic, thorotrast, benzene, benzidine, and all. Clear to everyone? Yes. Now, anti-TB drug side effects. कहाँ पे बता दूं? Okay. If we talk about anti-TB, a bit pharma, we cannot. Yes, I want to tell you bit pharma, but let's be confined to the PSM only. Let me tell you these side effects. For a pharma, we have HRZE. H for isoniazid. What is the side effect of isoniazid, guys? Peripheral neuropathy. Rifampicin, orange color secretions. orange color secretions. Z for pyrazinamide. Okay, pyrazinamide में क्या है? You have hyperuricemia, gout, hyperuricemia, hyperuric acid, I will write. That is gout. Okay. If I talk about ethambutol causes optic neuritis. Ethambutol causes optic neuritis. You have S-streptomycin called ototoxicity. Ototoxicity. Is that clear? And most common ototoxic drug is a kanamycin from the aminoglycosides, which inhibit which ribosome, 30S or 50S? 30S. Aminoglycosides and tetracyclines, 30S. At 30, yaad rakhna, baki 50S hai. Okay, and there is a one new drug for anti-TB called as we have BPAL regime. Okay, we have BPAL regime, bedaquiline, है ना? We have pretonomid and linezolid. These are the BPAL regime. And what is the mechanism of action of bedaquiline, guys? ATP inhibition. Okay, guys, ATP synthesis inhibition. What is the side effect, guys? QT prolongation. QT prolongation. That was all from the pharma bit, guys. Don't want to go deeper. Otherwise, okay, I will come back to that also. Okay, whenever having a leaving space, I'll come back to that topic as well. And there is a one question for that. Okay, you mean Delhi and all? Yes. Okay, let's go to this question. Clear, guys? Anything else? Cancers I've discussed, and as well as anti-TB drug side effects. You know, anti-TB drugs are important. Now, the next question, guys. 50-year male presented in medical emergency with the complaints of fever, headache. On examination, neck rigidity seen. Investigation confirms as a case of HIV with the cryptococcal meningitis. The possible CD4 count would be, what would be the possible CD4 count, guys, for the cryptococcal meningitis? What will be the possible CD4 count? Jalisha. Okay, guys, the answer is C, 200 to 100. 200 to 100. Guys, if I talk about more than 500 CD4 count, which opportunistic infection, guys? None. If I talk about 500 to 200, from 500 to 200, what are the infections we can have, guys? TB, Kaposi sarcoma. TB, Kaposi sarcoma. Yes. If I talk about 200 to 100, what are the infections for 200 to 100, guys? We have pneumocystic gyrovasi pneumonia. Okay, we have cryptococcal meningitis. We have cryptococcal meningitis. Is that okay, guys? And if you have 100 to 150 CD4 count, what is the infection you will have? Toxoplasmosis. What is the infection you'll have? Toxoplasmosis. If you have a less than 50, my dear students, you'll have CMV retinitis. You'll have CMV retinitis or Mycobacterium avium complex. Let's discuss one by one, guys. Not gonna go deeper, guys. Let's discuss the treatment part. The drug for CMV retinitis will be, the treatment for CMV retinitis will be, it was the question asked, Jancyclovir. Will have a pizza pie appearance and the cotton wool spots on an eye. What will be your answer, guys? CMV retinitis, Jancyclovir. Is that clear? Jancyclovir. Okay. CMV retinitis, what will be the optha finding? You'll have a cotton wool spots and pizza pie appearance. If I talk about toxoplasmosis, what will be the treatment for toxoplasmosis? What will be the treatment for toxoplasmosis? Candida will be 500 to 200. लिख दो Candida यहाँ पे. Okay. The treatment for toxoplasmosis will be leucovorin. It will be, yes, pyrimethamine and sulfacidine. But in pregnancy, what will be your treatment, guys? Paramycin. your treatment will be sparomycin. Along with that, if ophtha mein aayega toxoplasmosis, head light and fog appearance. You know that ophtha better than me. Head light and fog appearance. Head light and fog appearance. Then if I talk about cryptococcal meningitis, if I talk about cryptococcal meningitis, what will be your drug of choice? L-amphotericin B. Which ink we use, guys? India ink. And guys, Indian ink. Okay, if I talk talk about pneumocystic girovacin pneumonia, the prophylaxis and the drug of choice will be cotrimoxazole. It will be cotrimoxazole. Let me write it clearly, guys. It will be cotrimoxazole. Okay, there will be perihilar opacities. There will be perihilar opacities. Yes, Gomori methamine silver stain, GMS stain in pneumocystic girovacin. Is that okay, guys? All clear about the opportunistic infections? Okay, and this neck rigidity, fever, headache is a triad of meningitis. You have two signs also, Kerning sign and Brudzinski sign. Depending upon a type of the meningitis, I've already mentioned a couple of times. Revise that table from the medicine point of view, guys. Then the drugs. That's it. Is that clear? Is that clear, guys? Opportunistic infections. Yes, sir. Okay. Then the question, then we'll have a break. Okay. HIV positive mother who is taking ART treatment delivers a healthy baby with a birth weight of 3 kg. With a birth weight of 3 kg. Started ART treatment just 4 hours after the delivery. What is the level of the prevention of the baby here? What will be your level of prevention, guys? What will be the level of prevention? What will be the level of prevention? Very good. Yes. Guys, the risk factor is already present. So we are giving the treatment to prevent the baby. The answer will be very good. B. Yes, that is a primary prevention. कौन सी prevention है, guys? B. It's a primary prevention. Okay, let's discuss pathogenesis of the disease. We have two phases. We have pre-diagnosis is for the mother, not for the baby. You are giving a treatment to the baby. Harleen, you are giving treatment to the baby. Okay, mother is already positive. Okay, so you are starting treatment in the baby as a prophylaxis. So risk factor is always present. Mother is already HIV positive. There are high chances of the transmission. So for the prophylaxis, if you are starting the treatment, that is a primary prevention. Okay, so guys, pre-pathogenic phase. We have pre-pathogenic phase. And guys, we have pathogenic phase. And we have pathogenic phase. In pre-pathogenic phase, we have two things. Okay, either we'll have primordial, or we have primary, Okay, in pathogenic phase, we have two things, guys. Either we have early secondary, or we have late tertiary, Okay, so guys, let's discuss this one by one, guys. If I talk about primordial, in case of primordial, guys, prevention of occurrence of risk factor. You don't want a prevention of occurrence of risk factor. You don't want a risk factor to come. Okay, so you are preventing the risk factors. So prevention of risk factors is primordial. Then the primary, prevention of disease. Okay, in presence of risk factor. Now the risk factor is present. But you want to prevent the disease. Okay, that is a primary prevention. In secondary prevention, okay, early detection and treatment. Okay, Okay, guys, early detection and treatment, all the screening test. Very good. Yes, all the screening test. Okay. So for example, if the father is having a hypertension, then his son is going to check the blood pressure, going for the lipid profile, CBCs, and all the investigations. Okay. So that is a secondary level of prevention. All the vaccines are which level of prevention, guys? Primary level of prevention, specific protection, primary level of prevention, है ना? But I have mentioned a one case, guys, the BCG vaccine that we use for the bladder cancer. The BCG vaccine that we use for the bladder cancer is a which level of prevention, guys? At that time, bladder cancer is already there, disease is already there. Okay, so you are just giving the treatment. That is a secondary level of prevention over there. That is a secondary level of prevention over there. Then, guys, tertiary. Okay, that is the management of the complications and disability. Management of complications and disability. So that is a level of prevention, whether it is a primordial, it's primary, it's secondary, or it's tertiary. Is that clear, guys? Level of prevention, we have pre-pathogenic phase and pathogenic phase. Clear, guys? Can you go to the next question? Everyone? Yes, sir. Okay, good. Vikalp, good. Okay. The STD kit used for the treatment of gripped painful vesicles leading to the painful ulceration over vulval area under given the program Suraksha. Which kit you will use under the Suraksha program? That what was the Suraksha program? Let me tell you first, guys. It's a symptomatic approach to the patient. Okay, it is not based on the diagnosis. It is based on the symptoms. Patient is coming with the pain abdomen, है ना? Patient is coming with the uterine tenderness, cervical tenderness, motion tenderness. You are suspecting a pelvic inflammatory disease, so you are giving kit yellow. Patient is coming with a vaginal discharge. You are just whether what type of the discharge it is. They are just classifying out this on the basis of the symptoms. For example, you are not going into the diagnosis, whether it's a curdy discharge, whether it's a frothy discharge, whether it's a creamy discharge. Just you have to prescribe the kit. Okay, patient coming to you with a vaginal discharge, you are just giving which kit color? You are giving which kit for the vaginal discharge? You are giving green color kit, but that is not a particular diagnosis. So it is a syndromic approach or the symptomatic approach. Okay, that is what these kits are used in the Suraksha clinic. As per Suraksha clinic, if the patient will having a grouped painful vesicles leading to the painful ulceration. Okay, guys, leading to the painful ulceration. So which kit you will use? Tell me the answer. Tell me the answer. Very good. Which kit you will use? Grouped painful vesicles. You just see, guys, in my slides, I've mentioned clearly herpetic. If there are herpetic ulcers, somebody is saying, sir, kit 5 white. Is kit 5 a white color? Is kit 5 a white color? Herpetic is red. Okay, red is which color? Red is, sorry, which kit? It's 1, 2, 3, 4, 5, 6, 7. SK, Nishant, 5 is white. Sorry. Yes, yes, 5 is red. So what is the answer? Okay, guys, I have wrote the multiple times. I have wrote it multiple times, guys. It's kit 5 here. Option is red. Okay, came 2 times. Yes, 5 is red. So what is the answer now? What is the answer? It's just a typing mistake. Sorry. So answer is kit 5 red color. Kit 5 red color. Okay, guys. So let's discuss these kits one by one. Okay, let's discuss these kits one by one. Okay. If I talk about gray color, that is a kit 1. Which color is kit 1, guys? Gray color. Which discharge? Which discharge, guys? For kit 1, which discharge? It is anorectal discharge. Anorectal discharge or urethral discharge or urethral discharge. Anorectal discharge or urethral discharge. Okay, what are the medications in the kit gray? Let's write medication as well, guys. we have cefixime, that is a cephalosporin, as well as azithromycin. Is that clear, guys? So kit 1, if the patient is coming with the complaints of a urethral discharge or anorectal discharge, the kit that will prescribe is kit 1, which is which color? Gray color. Okay. And the treatment, the medications inside the kit is cefixime and azithromycin. Cefixime is a cephalosporin, and azithromycin, you already know, macrolides, है ना? Macrolides. Then if the patient is coming with the vaginal discharge, which kit you will use for vaginal discharge, guys? Which kit you will use for vaginal discharge? It's kit 2 green. It's kit 2 green. For which discharge? Vaginal discharge. Vaginal discharge. Okay, vaginal discharge. Let's recall from the vaginites that we have studied in the OB-GYN. So guys, if there is a curdy discharge, what will be your diagnosis? For the curdy discharge, it is candidiasis. If you have a greeny discharge, you have a greeny fraud discharge, it will be trichomoniasis. Very good. If you have a creamy discharge, that will be bacterial vaginosis. Which criteria we have in bacterial vaginosis? Amsel's criteria. What criteria we have, guys? Amsel's criteria. Then we have if test positive, clue cells present, we have a creamy discharge, and we have a fishy odor, right? That are, out of 4, 3 should be present for the bacterial vaginosis. And what is the drug of choice for bacterial vaginosis? Metronidazole. What is the drug of choice? Metronidazole. Is that okay? And it's the most common vaginitis. It's the most common vaginitis. Then the second thing, guys, trichomoniasis. Okay, trichomoniasis. We have which type of discharge? We have green discharge. Okay, we have green discharge. What is the drug of choice, guys? What is the drug of choice? Again, metronidazole. Okay, and too much of inflammation. Okay, which appearance we have on the vagina? Strawberry vagina, also known as colpites macularis. Very good, colpites macularis. Okay, yes, and both partners are treated. Both the partner is treated. Okay. Then the candidiasis, guys, curdy discharge, and the drug of choice for candidiasis will be fluoroconazole. Drug of choice will be fluoroconazole. Is that clear, guys? All clear? These vaginites. So kit 2 green, we give vaginal discharge. Okay, what are the drugs that we have there? We have fluoroconazole in kit 2, kit green. We have fluoroconazole, and the second one we have signerazole. Fluoroconazole and signerazole. Okay, then guys, if I talk about white, white is which color, guys? Kit 3. White is kit 3. You have to give it for genital ulcers. Herpetic or non-herpetic? Non-herpetic. And respond to penicillin. Then you have blue. What are the drugs in white kit we have, guys? What are the drugs we have in white kit? We have benzathine penicillin. And azithromycin. Benzathine penicillin is also a drug of choice for which condition? Syphilis. Okay, benzathine penicillin is also used for syphilis, but not for neurosyphilis. For neurosyphilis, what is the drug? Aqueous penicillin. Yeah. Okay. So benzathine penicillin for the syphilis, but neurosyphilis mein aqueous penicillin. Very good, Vismedas. Okay. Then the another kit we have, guys, is blue color. Okay. It's which kit? Kit number 4. This is used for genital ulcers. Non-herpetic, but allergic to penicillin. Okay. And what are the drugs inside, guys? We have azithromycin and doxycycline. and doxycycline. Okay. Then we have red. Red is for herpetic, kit 5. Red is for herpetic, kit 5. So what will be the herpetic, guys? Acyclovir. Very good. Acyclovir. Then we have yellow. Yellow. Yellow is kit 6. That is for PID. And guys, mainly for the PID, lower abdominal pain and all. Okay. What are the drugs, guys? We have cefixime, we have doxycycline, and we have metronidazole. We have metronidazole. Okay. Then we have 7, the last one, black. The last one, 7, we have a black. And black is used for, guys. And we have a last one, black, kit 7. It's used for inflamed lymph nodes, inguinal bubo. Inflamed lymph nodes. Is that clear? And the drugs are azithromycin and doxycycline. Okay. Guys, they're already mentioned in my workbook. Let me show you guys. Okay, here. Okay. So syndromic approach, see. So these are the gray color, green, white, blue, red, yellow, black. Everything we have mentioned over there. And medicines, we have particular kit having a particular medication depending upon the symptoms. Okay. And I mentioned that it is based on symptoms, not on diagnosis. This is the logo for the Suraksha Clinic, Sexual and Reproductive Health Service. And these are the kits that are prescribed. Okay. Done. You already have, but back in there, guys, we have discussed a lot of things while discussing this QT prolongation, side effects and all. But right now, sir, share workbook. Yes, you already have my workbook, guys. Okay. All those students who are in my class already have my workbook, but those who are not in my class, I'll share the workbook later on. You can just ping me on my Telegram. Is that okay? Clear to you guys, this question? Yes, all clear? Everyone? Yes? Okay, guys. Yes, after this question, we'll have a break for 45 minutes for the lunch break, okay? Now, which phase of the clinical trial checks the efficacy and monitors the adverse reaction of a new drug? Which phase of the clinical trial checks the efficacy and monitors the adverse reaction of the new drug? Efficacy. Efficacy. Which stage you'll have efficacy? Very good, guys. It's phase 2. It's phase 2. Okay, let's discuss all the related MCQs, guys. First of all, if we go for preclinical trials, if we go for preclinical trials, the preclinical trials we do on animals. Preclinical trials we do on animals. Then phase 0. Phase 0, guys. Phase 0, we'll go for microdosing. Microdosing. Okay. Then phase 1. Then phase 1. Then phase 1. We check the safety of the drug. Then phase 2. We check the efficacy of the drug. Then phase 3. Comparison with the existing drugs. Comparison with existing drugs. Then we have phase 4. Check for long-term side effects. Long-term side effects, okay, in phase 4, because after the drug is in the market, then only we'll come to know about the side effects later on. Okay, so that is phase 4. Now, guys, simple MCQs that they can ask is release of a drug in market. After which phase release of the drug in the market? Phase 3. Release of drug in market. Okay, longest phase. Which phase is longest phase, guys? Phase 4. RCT is done in which phase, guys? Phase 3. Okay, most important phase. Most important phase. Phase 3. Once it's been compared to the other drugs. Maximum drug failure. Maximum drug failure. Maximum drug failure. In which phase, my dear students? Which phase? If the drug has not efficacy, right? Even if you take 10 kgs of paracetamol, your headache is not relieved. Failure of the drug, that is phase 2. Yes or no? Efficacy is important. Yes. Post-marketing surveillance. Post-marketing surveillance. Post-marketing surveillance. Post-marketing surveillance in phase 4. Post-marketing surveillance is phase 4. Is that clear, guys? Clear? All these things are clear? Yes. Okay. So all the topics that we have discussed so far, anyone with any doubts? So for all the topics that we have discussed, any doubts? Okay, everything is clear. After, in the end, I will revise that. So far, whatever we have studied from the above things, everything is clear, guys. Are you able to solve the questions? Are you able to recall what we have studied? Okay. PSM was repeated, yeah, 2 times. Sir, you revised very well. Thank you. Thank you. Thank you. You're welcome, guys. Okay, speed was okay. Any doubts from a gynecology, dermatology, and anesthesia? All these subjects that I'm teaching you guys, if you have any single doubt, you guys can just tell me. Okay. Yes. Okay, guys. So we'll have a break. We'll have a break for like 40 minutes, lunch break. Then after that, we'll start. Okay. We'll start sharp by 1:45. Okay. So till then, any doubts? Check out your notes, guys. We'll discuss further. Yes. Okay, guys. Thank you.